Thank you very much, Martin. Colleagues, ladies and gentlemen, good morning. First of all, I'd like to thank the World Cancer Research Fund for having convened the meeting, but perhaps even more for having established this project of coordination of scientists and policy makers around the prevention of cancer. And we at WHO are very much appreciative of this great initiative. So thanks for the invitation and for giving me the opportunity to share some of my thoughts. I will start by saying that cancer is not only a scourge for people's health and well-being, but it is a major threat to development. In all developing countries, cancers now account for a large enough share of premature deaths and poverty to merit an urgent and coordinated public policy response. Cancer causes more than 5.5 million deaths per year in developing countries, including about 2 million premature deaths occurring before the age of 60. And if we do not take action to counteract this, we'll see that in 2015 we'll have 6.7 million and 8.9 million in developing countries affected by cancers in 2030. But just to link it to the development argument, the morbidity and premature mortality is also linking to a considerable loss of productivity. This is an India example where you can see that cancers greatly increase the likelihood to fall into poverty due to catastrophic out-of-pocket expenditure and lost income from ill health. Just an hospital stay for cancer could account to up to 80% of the income per capita in a country like India. So why are developing countries more affected than developed countries? Well, two main reasons. First of all, the increased exposure to risk factors. So population in developing countries are exposed to the four main modifiable risk factors for cancers: tobacco, diet, physical activity, alcohol, as well as the cancer-specific risks such as infections and carcinogens. The second important reason is that in developing countries, the poor and the most vulnerable do not have access to health care. So health system cannot respond effectively and equitably to healthcare needs of people with cancers. And then we have, of course, the underlying drivers that, in addition to population aging, affect cancer risk in developing countries, and particularly poverty, globalization of trade and marketing, and rapid unplanned urbanization. So why are the poorest in developing countries most affected? And you see here a very interesting example from the tobacco consumption, and you see in developing countries, particularly in low-income and middle-income countries, you see the quintiles with the lowest household income are, for example, the one in which the prevalence of smoking is highest. So what can we do about it? And a very important fact is that 1/3 of the cancers can be prevented. There are affordable solutions that exist to potentially prevent 1.7 million deaths every year in low and middle income countries. So just with prevention, low cost interventions, we can prevent 1/3. And then, of course, the possibility to scale up and improve the quality of service delivery would be able to respond and take care of the needs of another third, 1.7 million cancers. I'd like now to turn specifically to today's discussion, linking nutrition to the prevention of cancer. And what I will do is I will actually start from the Diet and Cancer report developed by the World Cancer Research Fund and the American Institute for Cancer Research in 2007. This report, as you know, has extensively analyzed the science to highlight food and nutrition factors associated to cancer risk. And we highly commend this effort. First of all, because it has given us a good state-of-the-art perspective, but also because it has set a standards of a methodology to analyze science and link it to policy making. Now, this report has led to a series of recommendations that have been later taken up by the 2009 policy report. WHO has been an observer in this panel, and we've tried our best to contribute. And without the ambition of being systematic today, I would like just to look at the state of implementation of these different areas of recommendation, just to have an idea of where we are with it. And is the policy environment actually mature to cope with a challenge and to try and achieve that 1.7 million prevention every year? As I said, I will not be systematic, and luckily, my colleagues will provide more information on some of the risk factors. But I'll start with the physical activity level. And as you know, we publish periodically reports on the burden of disease analysis. And this is the report that came out last year, 2009, but it analyzes the data of 2004. And this is the situation of physical activity levels in different parts of the world. So if you just look at the left column here, which is the world situation, and if we pool the insufficiently active with the inactive, you see that the majority of the population, 60% of the world population, is actually insufficiently active and inactive, with some small differences across regions. But the reality is that we really have two-thirds of the population who are exposed to this risk factor. I was trying to think of how to report about the other important factor, which is the energy density of the diet. And actually, we do not have a good way to calculate and to globally, particularly to global monitor the energy density of the diet. So I thought we could consider the fat supply as a proxy for it. And we can certainly see that in the last 40 years, there has been an increasing trend in the consumption of vegetable oils. This is the world figure. The animal fat has actually been relatively stable, particularly because we have had a decrease in developed countries and a slight increase in developing countries, so that has compensated. But the important concept is that overall we have had an increase in the consumption of fat, and this has most likely led to an overall increase of energy density. The fatty acid composition of these different vegetable oils is also remarkable, and that increase you've seen in vegetable oils has been particularly due to the use of certain vegetable fats as a replacement for animal fats in manufactured products. And you see the group here of fats which are widely used, coconut oil and particularly palm oil, which have a particularly high content in saturated fatty acids. So we should be concerned, in addition to the energy density of the diet, also with the quality of the diet, and particularly the quality of fatty acid in the diet. And just to give a specific example of the developing countries, these are data on per capita fat consumption in India, and you see in 20 years how there's been a progressive shift towards the highest proportion of consumption. These are grams of fat, and you see particularly going from the west to the east, and in the urban areas, in 20 years there's been a remarkable change in the pattern of food consumption. The estimate is about 1 to 1.5% per year increase, so a very quick increase in fat consumption. This is fruit and vegetables, and again I'm using burden of disease data 2004. Similar values for physical activity, around 70% of the world population not consuming the 5 portions per day of fruit and vegetables. But here with interesting differences, with Africa and Southeast Asia having a higher proportion of population with low consumption compared to, for example, Europe. And that's really a 20% difference in the exposure to this risk factor. Just to go a bit more in detail in the African situation, these are consumption data put together by International Food Policy Research Institute. And you can see there that the consumption patterns range from 27, very low in Ethiopia, to 114 kilograms per capita per year. Now, the amount that we should be consuming, if we consider the 400 grams per day recommendation, should be 146 kilograms per person per year. So you see how far, this indicates really how far we are from that goal in some of these developing countries. Of course, the demand rises with increasing income, and fruit and vegetable is higher in urban areas where the supply is more constant. And interestingly, female-headed households spend more on fruit and vegetables. So you see how also social factors and supply factors are conditioning this important risk factor. This is the proportion of energy that comes from animal source food. Animal source food is also another important risk factor for many cancers. And this analysis has been done by FAO on a selected group of countries. But, so just looking at some developing countries like, for example, Brazil and China particularly, you can see that in 20 years there's been a major, remarkable increase in the proportion of energy coming from animal source food. So China, we've seen really the proportion of energy coming from animal source food quadrupling, increased 400% in the last 20 years. You see China with this very large increase. Not all countries have undergone this change to the same extent, but see typical important large countries in South America like Brazil or Chile, Colombia increase, and important countries in Asia, in addition to China, also India and the Philippines, again, large increase in animal source food. This slide is taken from the policy report and tells you about alcohol data. It's remarkable how we, considering our knowledge about the importance of alcohol as a risk factor, the fact that, in fact, except France, in most countries we've had other stabilization of the consumption or even a moderate increase. And now just France has come down to the level of most European countries. But certainly there has not been the decrease that we all auspicate. WHO has worked a lot on an alcohol strategy, which has now been approved by the World Health Assembly last May. So we hope that in terms of policy making, this might push the agenda even further. Salt and processed foods. Again, we do not have comprehensive data. So just use this as an example. Salt and processed foods, we can think of snacks, for example. And this example of Thailand is really striking, because if you look at the dates here, you see this is 1999 and this is 2004. And this is the consumption of different types of snacks. Most of them are actually salty snacks. And you can see that in only 5 years, there's been the increase in the volume of retail sales. These are tons, I think, yeah. It's gone up by 50%, so almost 500,000 to 750,000. That's in only 5 years. So it's remarkable, rapid increase. And this is a situation which is not only for Thailand. In a lot of emerging markets, this has happened. I think we can quote the example of Mexico as well. And just to finish my overview of the risk factors, this is the data we're using for exclusive breastfeeding rates. And you can see that we have been remarkably good at improving exclusive breastfeeding rates with a number of initiatives in the 80s. And now this is the global figure. The prevalence of exclusive breastfeeding up to 6 months is not growing, and maybe it's actually decreasing. Different reasons, more women in the labor market without appropriate legislation, but also still aggressive marketing of breast milk substitute, particularly in emerging developing countries. I'll now move to a second part of my presentation, which was opportunities and challenges. But actually, I always prefer to start with the bad news, so I'll start with the challenges. And I must say that the picture I've given you, although not systematic, points towards most risk factors going the wrong way, particularly in the context of low and middle income countries. I will try to address the issue as to why this is happening, indicating that three main challenges might be responsible for this. First of all, the strong trends in the development of the food system. The second is inadequate policy implementation. And the third is a low profile of the non-communicable diseases issue in the development policies. So you're probably familiar with this slide. This was in a very nice FAO publication produced by Branca, and it really summarizes the issue around the changes in food system with economic and social drivers leading to changes in the food supply, greater availability and affordability of products with higher content of fat, sugar, and salt. And the foreign direct investment in developing countries has played a very important role. Remember that foreign direct investment was allowed by trade liberalization. So in a sense, it was the price that developing countries had to pay to the structural adjustment. So there's nothing they could do about it. But what has happened is that this has favored nutrition transition, increasing the amount of highly processed foods in the global diet. So transnational food companies have grown, and they're investing much more in emerging markets. This is just an example of a fast food company. You see the blue part is the domestic market, and domestic market is shrinked in proportion, of course. And the markets outside the US have grown, particularly in Asia and the Pacific, you can see. So this has led to transformation of the food supply chain and food system as a whole in different ways. New forms of competition, new ways to sell and promote food, even new cultural identities for cultural foods, which have become like culturally acceptable and desirable in a lot of developing countries. These foods are more available, they cost very little, and they are very desirable. Another important aspect has been the concentration of trade. So the growth of supermarkets, they're also managed by transnational companies, and they've replaced local markets. So they've shifted demand for home-produced foods, foods purchased in open markets, to store-bought foods supplied by transnational food companies. So you see the two are connected. It's very interesting data. I heard from Carlos Monteiro in Brazil, really demonstrating the great shift in the food pattern that is taking place, again, in a few years as a result of these major changes. People are not cooking. People are buying pre-processed food much more in supermarkets. It's easier for them. It's even more affordable. Another aspect of the growth of supermarket is the control they have over the supply chain. And for example, the export of fresh vegetables from Africa to Europe, thanks to supermarkets, has increased a lot. So, and that's perhaps is another reason why the fruit and vegetable availability and price in Africa is still low, because most of the fresh market is actually moved to Europe, particularly UK has been active there. And final point I just would like to put in the picture is the increase in food prices. This is creating major humanitarian challenges, of course, in some countries, but in general it has led to a deterioration of the quality of the diet in many countries. And what is worse is that this could be a permanent phenomenon in view of the production induced by climate change. I think this overall trend in food supply is something we should be really careful in assessing to discuss the feasibility of our policy recommendation. The second challenge is a policy challenge. We have a good international policy framework. We have the WHO Framework Convention on Tobacco Control, a global strategy on diet and physical activity, now a strategy to reduce harmful use of alcohol. We also have good regional nutrition strategies. And you see here in Europe, in Eastern Mediterranean, in Africa, in Pan American organization. And these strategies are actually addressing non-communicable diseases as well as undernutrition. But when it comes to the country situation, you see that these strategies are not always reflected at country level. This is an analysis we have recently performed at WHO. This actually covers 117 countries out of the 193, so it's not totally comprehensive. But just to highlight a few issues, comprehensiveness of nutrition policies. And you see here, for example, this is the overweight, the blue column, and this is African countries. And only 1/3 of the African countries think that overweight and non-communicable diseases is part of their policies. But I also would like to highlight, for example, the issue of vitamin and minerals. In Europe, we don't have a policy around vitamin and minerals. It's very much left to self-regulation often. And when we look at these policies, we have to say that in terms of the tools they use, they are mainly dealing with information and education, and less often they're dealing with the supply side. You see important issues like healthy food at the workplace or the salt content of processed food, the issue of reformulation. Although it's there in theory, in practice, it's not implemented in the majority of countries. So I must say that policy is inadequate overall. And finally, final challenge is the profile, importance of the NCD policies in the development agenda. And see that statement there indicates that although policymakers often think of the importance of cancer, they do not find the suitable interest in donors, for example, in development agencies to implement their agendas at country level. This is just a figure indicating where does the money go to. And you see the money mainly goes to communicable diseases. So is there any hope? I think there is. And first of all, in terms of policy making, we should be considering the incredible innovation that is coming in a number of countries. And the second one is perhaps we can create an opening for NCD policies in the development agenda. First, I would like to say that intersectoral action is receiving much more attention than it used to be. We know what it is. We have examples of countries who have been able to address nutrition in a comprehensive way, looking at different sectors. And you see this is an example from Slovenia. Nutrition is included in agricultural policies. They are discussing it with industry, even finance, with considering taxation of different types of food, culture and social affairs. The Norwegian Action Plan also involves 12 ministries. And I cannot avoid to mention the Finnish initiative. I think they are the ones who have been pushing most for health in all policies. Now there's a European Union resolution on health in all policies. And really this is going in areas where we thought that health could not have access. The dialogue with the finance department, for example, and the whole issue of taxation of foods, in a differential taxation of food, is becoming a reality with countries implementing it. The second aspect is the link between agriculture and nutrition. There's been recently a summit in the Pacific in Vanuatu, where, as you know, the Pacific Islands have a major problem of quality of food supply and major problems of obesity. So this has become higher in their political agenda. So the summit was considering the importance of dealing with enhanced and sustainable production, processing and trade of safe and nutritious food. So Prime Minister have actually stated this. This is a good example. We hope that with the collaboration with the Food and Agriculture Organization, WHO will be able to expand this discussion at the global level. There will be an international conference on nutrition in 2012, 20 years after the landmark 1992 first international conference of nutrition. And finally, the use of legislative and fiscal tools, as I was saying, is becoming very serious, particularly again, the Pacific Islands, who have considered import laws or restriction of the use of ingredients, controls on advertising as an important policy measure to address their health issues. The other opportunity is the advocacy opportunity. In WHO, we have developed an action plan on non-communicable diseases. It has 6 objectives, and one of them is really raising the priority accorded to NCDs in development work. And we've tried to involve policymakers at a high level. We've called a meeting of the Economic and Social Council of the United Nations. This meeting has led to a ministerial declaration, which has then landed in the General Assembly. So last April, the General Assembly passed a resolution, and this resolution is calling for a non-communicable disease summit next year in New York. In September, there's always an important UN General Assembly meeting. This year is dealing with Millennium Development Goals. So ministers thought that since the NCD agenda is not currently part of the Millennium Development Goals, there should be a special session addressing this. So this is going probably to create a large discussion and hopefully a large resource mobilization on the issue of non-communicable diseases. There will be a lot of preparatory meetings and activities, and I really hope that we will be able to collaborate on this preparation with the World Cancer Research Fund. So I'd like to conclude here by saying that my assessment of the situation is that nutrition risk factors for cancer are not moving in the right directions. And this is particularly in low and middle income countries. And that's where we have to be concerned most, because that's where we're going really to have a large part of the increase in cancer global deaths. The second point is that policies and actions addressing physical, environmental, economic, social, and individual factors, just to quote the areas of the report, are not implemented. So we have to support countries to advocate for the important policies. And we have to also help them find the right appropriate solutions for their own context. Third point is that there are important political opportunities ahead, and we have to use them. So this is a time to act, to develop a better policy environment. But then we need some tools. And I think this audience would certainly have a lot of the resources who can help developing these tools. And I would say 2 things. One is a better system to track the implementation of policies. And we need to know what's happening. We need to see whether the recommendations are followed, because we need to set up an accountability system. And second, we need more research on implementation tools. We need to provide practical solutions, and we need to see how these solutions fit the different country needs in a complex, moving environment. So policies are something which needs to be adapted to the global trends. And I was asked to say whether I had a conflict of interest. I don't think I have, except that I'm an advocate for public health, of course, and I've been part of the policy panel, so up to you to decide whether it's a conflict of interest or not. So thank you very much for your attention.